Hello and Assalamu alaikum. This is Dr. Saad from Dental News, and today we have a very special guest for our interview, and he is Dr. Mohammad Ahmad Javaid. He is a board certified periodontist and implantologist from Canada. He did his basic BDS degree from Pakistan, and then he did his 1 year fellowship program over here in Pakistan again. And then he moved straight to Canada, where he did his two masters, and now with the great honor and respect, I would like to introduce Dr. Mohammad Ahmad Javaid to you guys. So here goes. So Dr. Mohammad Ahmad Javaid, how are you doing?
Assalamu alaikum, Jay. I'm doing good. Alhamdulillah. Thank you. Thank you.
Right,
Thank you for
sir.
having me. I really
So,
appreciate it. Thanks.
sir, since you're a periodontist, so I know it will be a very a cliched conversation, but yes, let's try to make it sound really helpful for the audience as well. And I hope you have a great time with us.
I appreciate it. Thanks for having me.
All right, sir. So the first question would I would like to ask you is, sir, why the main question, why did you choose periodontology?
So the basic answer is when I was growing up in Pakistan, I was in dentistry. I did my basic dentistry from Pakistan, like you mentioned, FMH College of Medicine and Dentistry, Lahore. During that time, all the specialties were very well established in Pakistan. I think pretty much we had all specialties since 60s, probably 50s. I'm not aware. But by 2000s, all the specialties really nicely well established. Surgery was amazing, and so was ortho and all the other specialties. One specialty which was not established, and we did not have a single fellowship program in Pakistan. And in Pakistan, for those who do not know, in Pakistan, it's different. For example, in US, what we have is Diplomat. That's considered the top qualification. That's what you aim for if you're a specialist. In Canada, it is fellowship. And in Pakistan also, it's fellowship. So it's called FCPS. In Pakistan, we did not have FCPS. I think it only started in 2016. And as far as I know, there is only one institute, which is my parent institute from Pakistan, which is approved for training of FCPS right now as we speak. So we didn't have perio back home in that time. And I knew in undergrad studies, I believed, and after my experience, limited, whatever it is, even in North America or Canada per se, I think my belief has been reinforced, which is in undergrad studies, we learn about pretty much almost all facets of dentistry. And even if we don't know, even if we don't go in great depth, we still get a good hang of it. Except surgery and orthodontics, we don't get full appreciation. We don't get good idea, and we don't do any major surgeries or ortho treatment. So those two fields have always been really close to my heart. Specifically perio, because I remember in the final years, you're influenced by your teachers, your mentors, people you really like, appreciate, and follow. I liked surgery. I also really like aesthetics. And so perio was considered plastic surgery, and it was considered something really sleek, nice, pretty, awesome. But we did not know what perio was. So it was more of a mystery, which increased its intrigue for me. And I felt that, I really, and then we had an instructor, Dr. Furamathawla. I think he was one of the very few who had come from Singapore. He did his membership. He had done his membership, I think, around that time. Now he's a fellow with Royal College, England or Edinburgh. But he had come in and he was that role model, if you will. And we were just following him. And he was the first one who introduced even Kevitron. And and I would like to emphasize here, any other specialty in Pakistan, it's top notch. The standard is unbelievable. It's amazing. And I cannot and I say it after I've been lucky. I've been really privileged and lucky and fortunate, and I'm grateful that I've had the honor and opportunity to be involved in 3 universities in dentistry in Canada. And I take pride in it, and I'm grateful and I'm humble. But I still have to say that, McGill, University of Alberta, University of British Columbia, and after seeing their systems, I can say that, dentistry, other specialties in Pakistan, they're really good. But when it comes to perio, we we were lagging. We were really lagging. And all this increased the intrigue, the curiosity, and I ended up picking up perio actually. And I absolutely enjoyed it, absolutely love it.
All right. So since you talked about all things are great over here in Pakistan, but you still have that question that perio is still, it's not up to that mark like the other specialities.
Yeah.
So, what do you think is the cause for that? What are your, if I say, if you can sum up in two main basic things, like what are the things which are lacking in Pakistan regarding Perio's, I wouldn't say downfall, but it's not there. It's like a single plateau regarding Perio.
One, I think it will take time. So if you think about it again, think of it this way. All the other specialties were established in the 50s or 60s. And today, when we're talking, it's been 60, 70 years or something like that, close to that, right? So it takes time, just like nations, just like anything. So it takes time. Perio in full scope, full-fledged Perio was only established in 2016. In fact, I remember Dr. Khurram contacted me and said, Mo, uh, can you, can you give me some input about the program in Canada and all that thing? And so I know although I've not been involved in it directly, but I've seen the Perio program take baby steps, and I'm very confident. I'm hopeful over time it will establish into a very nice specialty with all the facets of Perio being practiced. The other thing is, overall, I think we need probably, at least in my case, I felt when I was in Pakistan, I was very impressed by few instructors. And to this day, when I'm doing a procedure, just like yesterday, I'll give you an example. I was extracting a tooth, and once it was done, I cleaned everything up, added bone and whatnot. And I was telling my assistant, I said, every time I extract a tooth, it reminds me of my professor of surgery from back home, Dr. Abid. He would always say, Mo, never extract, ease it out. He could do it, despite having done many, many extractions and these procedures to this day. And I think I will never be able to do it. He could do it. I've not seen many people who can do it consistently. He just puts the elevator in. It's as if he's talking to the truth. It's amazing. So we need role models. We need people who are willing to share, who are willing to mentor, guide, and also I think the students as well, if they are willing to absorb, like it has to come together from teachers aspect, from students who are willing to learn, who are humble, who want to improve, want to learn. So I think it's a matter of time, and we just over time we will have hopefully more and more mentors and things will improve. Perio will get its due. I think it's just a matter of time.
Right. So I think I am also very inclined towards periodontics, and I think it's the same thing as if, as you just said, that you need that mentor and that person, who makes you realize how important this subject is. And
And those, like, if I apologize, I'll give you, and I cannot stress it enough. I apologize for, it's just you reminded me of something. I'll give you an example of it, of an amazing instructor. I am grateful. I am blessed for having some of the best instructors. One instructor, and I give this example in my lectures, and I openly talk about it because that changed me. And I try to follow that particular instructor. So I was placing, when I was in Canada in residency, that was my first implant case, and I was supposed to place 2 implants. The site was 3.6 and 3.7. Now it's a difficult site, especially if you're placing your first implant. So to give you, a lot of people may not know, but the idea is, let's say this is tooth number, let's say this is tooth number 3.5. So what you want to do is you want to follow the parallelism of this tooth. So the ideal implant would be just parallel like this. And my final year resident was assisting me. I did my initial drilling, and then I took a radiograph, which is like X-ray. So I took my radiograph, and once we saw the radiograph, the implant was actually coming this way, about to hit the root of 3.5. Maybe I was 2-3 millimeters short. As soon as my senior saw the radiograph, he gave me a nasty stare and he said, Mo, go and get Dr. Ganad. In my heart, I was thinking, I'm screwed, I'm done. So I go and I say, Dr. Ganad, sir, uh, can you please come? I knew that I have screwed up and this is going to be really bad. He comes in, he takes a look at the radiograph while he's at the door. He says, voila, that is beautiful. That is amazing. Excellent Mo, well done. Let me have a peek. He comes in over my shoulder, sees the area, and he says, Mo, you know what? This is amazing. Now let me show you a trick as to how we can improve it even further. He came in, he corrected everything. He stood there. After correcting, he made sure I placed the implant. Then for 3-7, he stood there, practically held my hand, helped me place 3-7 as well. When everything was done and over, everybody left the office. I went to the instructor and I said, sir, I'm really sorry. I have never placed an actual implant before. This was my first case. I apologize. And he looked at me and he said, Mo, don't worry about it, man. You'll be fine. This was my job to help you place implants safely. He did not shatter my confidence. He built it up. And I learned so much that day, not just from clinical standpoint, but I also learned how I should be trying to be a better person, better mentor. And I shouldn't be somebody who shuns people away. And that was by far my role model when I practice perio is Dr. Gana to this day.
All right. So, sir, you're talking about implants. So, sir, since the conversation is going towards implants, but we'll come back to perio again since you
Sure.
touched upon the implants. So, sir, over here in Pakistan, what you see is implant is number one. It's taught in the subject of surgery, oral surgery. So, do you think that's right? And the second question, in addition to that, is in undergrad, the amount of implant knowledge is not sufficient enough in Pakistan in the undergrad level. So, do you think that needs to be improved? Or do you think implants is something really, it's a speciality? Or do you think that the undergrad syllabus for the implants should improve, or it should stay as like, just a basic implant topic? Or do you think the undergrads need to know more about implants?
So from what I gathered, I didn't clearly get the first question. Let me repeat and please let me know if that's what you meant. The first one was that implants are considered the mainstay or a lot of focus is being put on the implant training in the oral surgery programs. And if that's a good thing or a bad thing, that's what I.
Yes, sir.
So with oral surgery, what we mean with oral surgery is in context of Pakistan, we have maxillofacial surgery, oral and maxillofacial surgery. And oral and maxillofacial surgery is, I am a big fan, and I cannot say enough nice things about oral and maxillofacial surgery. They are amazing people, and I have utmost respect for them. The stuff that they do is amazing, unbelievable. And I've seen some great programs. I have had the privilege to observe basically for 2 weeks. The oral and maxillofacial program at McGill was amazing. And I don't want to say I take pride, but oral and maxillofacial surgery is really close to my heart. Why? Because when I did my primary fellowship, FCPS in Pakistan, which again, for the people who do not know, back in my time, it was super competitive. About 1,000 to 2,000 people appeared in primary fellowship exam from Nepal, from Saudi, from UAE, from Pakistan, and only 30 people on average would pass out of all the pool. My batch was the first batch in which 62 people passed. I was one of them. After I cleared my FCPS, primary FCPS, my plan was if I stayed in Pakistan, I wanted to do either ortho or surgery. Why? Because we didn't have perio. And surgery or ortho, like I said initially, were the two fields where I felt are the ones where you don't learn much about them during the undergrad. So that was my plan. So oral surgery has a very special close place to my heart. Now, having said that, oral and maxillofacial surgery is a very big field. if I was an oral and maxillofacial surgeon, I would think that I would want to be the very best, and I would want to be able to deal with trauma and cancer cases. Like, I was blown away when I was at McGill. I know maxillofacial oral programs in Pakistan are top notch, second to none. And it's very important and it's very good that you place a lot of emphasis on implant, but there should be no compromise. You should increase the workload if needed, but the attention, for example, paid for cancer surgery, trauma surgery, none of it should be taken away. If more load needs to be placed on implants, good. But implants should not compromise the management of the other aspects. A resident should be able to completely master, not master, because in residency, even up in private practice, you don't become a master, but at least they should be competent enough to manage cancer cases. I know a lot of oral surgeons, oral and maxillofacial surgeons, even here, who don't feel comfortable doing cancer surgery. And I understand it depends where you've been trained, but that's where the emphasis should be. And then implants should be like a cherry. They should be really competent, and it's not difficult. I think like, yes, I understand all, like, generally a lot of implant cases are not they are not difficult compared to head and neck surgery, let's say, right? So there should not be a compromise on the oral maxillofacial surgery quality training, but implant should be on top of it, like, extra work for that. That's just my 2 cents. Number two, your question was about the implant knowledge, implant skill, implant training, education at the undergrad level, right? That's the second question. Now, with regards to that, I think when it comes to theory, yes, I believe at least the curriculum at my time, I think we lacked. We were not as much abreast with what was going on in the world, at least in my time. And theory is much better here, number one. Number two thing, implant is very closely related to the prosthetics. So I feel very strongly that the prosthetic side of things related to implant were not that much in our curriculum. So I feel that's what's lacking. When it comes to the practical side of things, the reality is, even as we speak today, um, undergrad students typically they don't do implants. That's why all the general dentists, once they graduate, they take either courses or they do specialties, because they really, if they want to excel, that's the only way. And I don't know. Honestly, I've not been involved in teaching that much. I don't have a very big data to analyze and compare and say, okay, if we were to do this, this would make a huge difference or not. But we are not that far behind when it comes to skill set at the undergrad level. Why? Because it's pretty much more or less the same here in North America. When it comes to theory and knowledge, yes, it's better here. With regards to implant and prosthetics of the implants, when we compare undergrad to undergrad. So I think that should improve in Pakistan.
Right, sir. So, since again we're talking about implants, so sir, what criteria would you establish when you give an implant? Like, who is the ideal patient to give implant? Because over here in Pakistan, there is like a conundrum when we talk about implants, because we're saying that it's either malpractice or it's either a money making tool. So since you've been there, done that, I don't know how many implants you've done, but since you have experience, so what is your basic criteria to place implants in a patient?
So first off, I'll say I, I wouldn't I, I wouldn't want to be associated with been there, done that, because I'm just another Joe. I'm student of perio and implant industry. I just want to learn more, and the more I learn, the more I realize I don't know much. I want to excel. I want to improve and learn more. Having said that, whatever little bit I know, I'll share with you, and I'll give you, like, it's a big thing, like, there are a lot of things that you go through, checklist, whatever, but I'll give you a couple of simple examples to make it simple. During residency, I placed an implant in a patient where there was a probing wise, when we measure probing, we periodontal probing or a had a 5 or 6 millimeter pocket or something. And I remember it became a big deal because it was my mistake. Now, and somebody looking from the outside may say, oh, they made a big deal out of it. No, they were right. My instructors were right. The thing is, they wanted to inculcate in me, they wanted to engrave in me the fact that one thing which you should be doing absolutely essentially before even thinking about implant is to ensure that there is periodontal stability. There are no deep pockets. If there are deep pockets, let's say an isolated 5 or 6 millimeter pocket, then there is a plan in set in which will take care of that. Or patient is cognizant of that. Patient is willing to take the risk that it may lead to peri-implantitis, mucositis, or implant failure. So I thought at that time, wow, did I do, God forbid, something really bad? And yes, the idea was they wanted this in me. Now, when it comes to placement of implants, I look at a lot of things, but this is one thing. Interestingly, my colleagues were, and I bring it up because I'm grateful to my teachers at UBC. My colleagues, I work at a very nice facility. It's a very nice. I work at two private practices, one of which is a specialty practice, very nice practice, and the other one we have general anesthesia even. So it's a very nice. I'm privileged. I'm grateful. And it was so nice that I was sitting amongst all my colleagues, and our senior periodontist was saying that she wanted to bring something up, and she said, "Before I bring it up, I want to say, Mo, you're already practicing it. For the rest of us, we need to make sure that more," she was saying, in every patient, even before he does any implant or anything, he just goes through the checklist, one of which is basically the probing and full mouth exam and whatnot. So if there are, and another thing I would say, so this is one thing which I think even in North America, not a lot of people do. They don't do the full mouth charting, which is necessary. Another thing is, which is very interesting, which is related to board exam as well. Back in the day, when I was preparing for my fellowship in American board exam, the question was, is keratinized attached gingiva or keratinized tissue important for implant health? And I remember, the answer would typically be, if you look at the literature, for example, Bori 2008, it states that when they compared the implants which had that versus those which did not, the probing depth, the attachment, the recession, the thickness of tissue, the aesthetics, the bleeding on probing, all those things were significantly, significantly worse for the implants which did not have keratinized tissue or attached gingiva. But the difference was not very statistically significant. So the answer would be yes, it is important, but clinically, it was statistically significant, but clinically not very different. So that was the answer. But now in my private practice, when I work, and we have seen it now that the importance of the keratinized or attached gingiva or keratinized tissue, there are different things, but the importance of attached keratinized tissue is there. It's there. So I tell my patients, if I am placing my implant, I would want to make sure that I do the best that I can, that my implant lasts a very long time. And if you think about it, when the implants were introduced in the 1960s, roughly speaking, Brandmark was the guy. When the implants were introduced, it's an era of 50, 60, they're still experimenting. Up until, let's say, 1990s, you wouldn't hear about peri-implantitis or peri-implant mucositis. Why is that the case? Think about it. You wouldn't hear much about it. And then suddenly in 2000s, it just blows in our face, peri-implantitis, mucositis, depending on what you read. So for example, if you read the paper from Cold Sled 2010, I think, depending on the definition you use, it varies from 5 to 11%. But if you read elsewhere, Lindy, European Workshop, the number is different, 38 to 83%. So the question is, why is that the case? The reason is, like you mentioned, that when they started placing implants, the criteria was so stringent that it was almost impossible to be enrolled in a program where they would place implants. You needed to have regular dental hygiene, optimal care, non-smoking, medically fit. no diabetes. If you had, it had to be perfectly maintained, all those things. What it led to was an environment in which implant would thrive. In today's world, when a patient comes in and has a missing tooth, that means an implant, right? Implant, implant, implant. Another thing I see very often, which is related to this, if a patient has 3 missing teeth, 4 missing teeth, 4 implants, 6 missing teeth, 6 implants. If there is a space, there's an implant. And I think, wow, wow. So it's a very long answer, but a lot of things, small things, bone, soft tissue, probing, lack of periodontologies, what is the smoking status, how's the oral hygiene? If those things are not there, then you're planning for a failure. Somebody says if you're not planning, then you're planning for failure. So if you're not looking into those things, then probably you'll end up with the bad implant. So I have had cases, I can tell you, in private practice where patient was willing to pay a lot of money. And I very politely, very humbly suggested that, let's try to control the other factors first, because otherwise, like, I don't feel comfortable placing implants. If the foundation is not right, if the basement is on fire, would you want to build a house on top of it? That's just my percent. So some of the things, I don't know if I've answered your question correctly, but I would look into these things, probing soft tissue, bone, and all those things. And then if needed, take, like, most probably I'll take a CT scan as well, CBCT, which is basically ensure I have measurement. Do I have 1.5 millimeter? I personally aim. So the thing is, when you're placing an implant, the literature says you want at least 1.5 millimeter of bone on the buccal of the implant. Me personally, I try for 2 or 2.53 if possible, more bone. So all those things. What is the occlusal load like? And are we taking care of the hygiene? Is patient committed? What is the smoking status? All those things.
All right, sir. Thank you for that. Sir, again, you talked about treatment planning. So, do you think it is the most essential step in commencing anything? Like before your skill set, your treatment planning should be up to the mark. What is your take on that?
So all things are equally important. Think about it this way. I'll give you 2 examples. Before you build a house, you need the design. The architect has to come up with a design, then the engineers or people who build the house, they actually build the structure. Same concept. Treatment plan is what gives you a blueprint to hopefully execute a very nicely placed implant, surgery, treatment, ortho, all those things. Having said that, I remember this question actually reminded me. I remember I went to my instructor, lit review instructor in residency, Dr. Hakkinen, God bless him, amazing instructor. And I said, sir, and like, I would like to acknowledge, I would like to take this moment and this question to acknowledge every residency has, like, all the programs have their pros and cons. And I am grateful for people and the program at UBC in Vancouver. One thing which made, in my opinion, UBC Perio very unique. I don't know now, but at least in my time. If somebody asked you a question, you would answer the question with a number of references. In my batch, at least, that was the thing. And the exam was that in the lit review exam, we would write a review paper with references. That was the exam. So if somebody was to give you a topic, you would write an actual review paper with all the references. So I remember I went to my instructor and not just the author, year of publication. So I went to my instructor and I said, Dr. Hakkinen, like, we read about diabetes, we read about smoking, we read about bone, all these things, but they are so random. Like, one day it's diabetes, the other day. Why there is no, I feel confused. And he told me, he said, Mo, trust me, by the end of third year or in the third year or somewhere there, you will develop the lateral connections. I didn't understand. And when I was finishing my program, I went back to him and I said, sir, I just want to thank you today. that the thing that you said about a year ago now makes sense. So when you are learning about treatment planning, let's say in a session you're sitting there teaching you, you have to consider these things. They form the basic concept of a treatment plan. In the other session, you're going, they're talking about flaps and whatever. It appears at that stage, or at least it appeared to me that I was bombarded with information. I couldn't, वो कहते हैं ना उर्दू में, I couldn't get the sira, like, from where do I start? We as humans, even in our school, we like organized things. In graduate level, you feel as if the information is being bombarded. And it takes a while before things, it's as if the pieces of the puzzle come together and then you can see the final beautiful picture. So treatment planning is essential, but all the other skills, all the other tools also need to be there. And you build everything together towards a crescendo where, like, things, the picture becomes visible, clear, and you can see and you're like, okay, now it makes sense. But coming back to what you said, treatment plan, absolutely essential. And one more thing, if you allow me, if I may add, not just the plan of what you're about to do. I try. I can't claim that I always do it or I've always been able to do it, but at least I try. This is my plan A. If for some reason it doesn't work, this is my plan B. And if it doesn't work, hopefully have a plan C. And I discuss it with the patient that I cannot guarantee you. Like, I take a lot of pictures in my surgeries and I show. Sometimes some people like to see, for example, I'll give you an example when I'm doing a connective tissue graft or I'm doing a coronal positioning of the flap. I've done it where people would be like, patients are like, wow, at the end of the procedure. When I show them the picture, they're like, wow. And I say, okay, listen, thanks, appreciate. But during healing is one thing which I cannot control. My pictures show that my surgeries hopefully are good enough. If I'm not the best in the world, I'm far from it. I would want my work to be really good. My surgeries show that. And I take pictures to show it to my patients and other people, but I cannot control healing. I know biological principles and whatnot, but everybody heals differently. So you should have a plan B and a plan C, hopefully. And if things don't work, you discuss it. One of my instructors, God bless her, used to say, explanation prior to the procedure is explanation. Explanation after the procedure is an excuse. So always prepare the patient for A, B, and C plans.
Right, sir. So thank you for that, sir. And sir, another question, which is, a part of the, you can say the dental talk here in Pakistan, is that the multidisciplinary approach. Because over here in Pakistan, you see that every every guy, every dentist, he tries, or he does things all on his own or all on her own. So do you think, is that something which is making the bar go down in Pakistan? Because as you said that you're a board certified periodontist, and your main specialty is periodontics, but you can do those other procedures as well, that operative dentistry, aesthetic dentistry, you can do that too. But since you have the speciality, because in Perio you would prefer to do that, but over here there's this, there's this black cloud, you can say, that every person wants to do everything on their own. So what's your take on the multidisciplinary approach?
So I'll break it down into two parts. One is what is my opinion or my take on the multidisciplinary approach. Second is that, we practice perio specifically here in Canada, let's say, whereas in Pakistan, people are doing everything. So, there are pros and cons of pretty much everything where you practice it included in that thing. So I'll give you an example. In Pakistan, so if I think from their perspective, let's say a periodontist working in Pakistan, if I think from their perspective, their problem is the way the private practice is, the way, like, I don't like to say it, but it's a reality that financial side of things are also very critical. They are very important. People have to pay bills, whether anybody, including myself, likes it or not, but that's the harsh reality. So in Pakistan, the problem is when the patient comes in, if you cannot do a root canal, the patient will go away, and you don't want that. So you do the root canal, you do the endo treatment or Invisalign or ortho or perio or whatever. Even if you're a specialist, there are a few oral surgeons I know maxillofacial who only practice that, but I know a lot of maxillofacial surgeons as well who are doing root canals as well because they want to make sure that they're paying the bills. And for people who don't understand, it's it it comes down to the financial side of things. When I did my house job, and I have no bar in saying that, I tell it to people all the time. When I finished my house job, which is the 1 year GPR residency, what we have here in North America. So when I finished that, I went into private practice. My first job, I was paid less than $80 a month. Okay. So, which I know if somebody was to hear, a dentist was to hear this, they would be like, oh my God, how's that true? But that's true. I made less than $80, and I am very grateful for that job. Very grateful. Having said that, so financial side of things is important, and sometimes that's what forces people back home to do stuff. But then that leads to other problems. In Canada, for example, in my case, I cannot practice anything other than perio. I'll give you an example. If I'm a specialist who specializes not just from license perspective, but from real life perspective, I'll give you an example. Let's say I'm a general dentist, born, raised, did my general dentistry in Canada, and then I became a specialist ortho or a perio, let's say, in Canada. Now, if I do general dentistry and specialty both, then people would not want to refer because here it's a referral. The specialty practice is a referral based practice. If I'm a general dentist, I will do my own cases. And if I'm a specialist simultaneously, I'm doing a specialty, I'll do the specialty cases. The general dentist from the other office would be my competitor as a general dentist. So they wouldn't want to send me the case fearing that the patient, when I do the specialty, the patient may not go back. So the mode of practice here is referral based for the specialist. So that makes it easy. That's the reality. So I don't blame people in Pakistan. Having said that, the problem is in Pakistan when you practice everything is you don't get enough of those cases which fall in your domain. So if somebody was to ask me, like the other day, not the other day, I'll give you an example. Actually, it's not a funny, but when I was in residency in UBC, my mom was visiting me and she needed a simple filling. So I went to the reception and I said, I want to have, can you kindly book my mom for with so and so? And they said, okay, Mo, we'll do it. What for? I said, simple filling. So the front desk staff, they looked at me and they said, what do you mean? You could not do a simple filling for your mom? I said, one, I'm not allowed, but even if I could, I don't feel comfortable. The last time I did a filling was, I don't know, 2009, 10, 11, somewhere there, 2011 maybe or 10. I have not done any for the last 5, 6 years. I feel more comfortable placing an implant or doing a gum graft or surgery than doing a simple filling because I've not done one for the last 10 years or something like that, right? So when you don't do enough, then then you're not in touch. And another example I'll give you is I remember I asked my professor. I was fortunate or unfortunate that I also saw an MI or a heart attack in a dental chair. And the way it was managed was top notch, unbelievable. Our oral surgery, it was Dr. Imtiaz, amazing, amazing. The patient had an MI, and everybody, I was in my GPR residency, house shop basic, and we were panicking, myself, my colleagues, everybody's. I was assisting, and I was standing there. Then the person who dealt with the MI, Dr. Imtiaz, he asked my class fellow, can you take the blood pressure? And I remember all the tools are like going in here. Nobody, we were panicking. He came in, he dealt with it very nicely. Amazing, amazing. Once it was done, I went to the professor and I asked him, sir, can I ask you a question if you don't get upset, whatever? And he said, no, go ahead. I said, sir, let's say if you were there, would you be able to, or if this thing happens, would you be able to manage it as competently, as efficiently and all? And he gave me a very honest and great answer. He said, Mo, I used to run code blues and emergencies all day long, and I've done it for 20 years or so. And I could do it sleeping. Now I have not done it for the last 5, 10 years or something. If I had to, I could, but I don't feel comfortable doing it. So if you're not in practice, you either use it or you lose it. So even if you do, like I am a strong believer, when we had quarantine, people were not going to practice. When I went back, I had not done a surgery in 2 months or something like that. I went there, and my first day I had 3 surgeries, I think, 3 or 2. Took me 5 minutes, not even 5 minutes, and I was in the groove. It was just all built in reflex. So if you have done a lot of those, like it's just like driving. If you do driving, I did not drive in Canada for the first, I don't know, 7 or 8 years, but the day I sat in the car, boom, came back like this. So if you've done a lot, like let's say you're a specialist in perio in Pakistan, you've done a lot and you've done well, so that you critique yourself. I look at my pictures, the cases, and I critique myself. How could I improve if I was to put my suture 0.5 millimeter here, there, all those things? I think about them. If you do your practice that way and you're doing endo, I'm pretty sure over time you'll be able to do great. Because I know a lot of general dentists here in Canada, in North America, who do all facets and they do great stuff. I know people, general dentists, who place implants better than me. I can say it openly. I know general dentists who do perio better than, so if you do a lot of volume and you're critical of yourself, you want to improve, then over time, even if you're practicing in Pakistan and you're doing a lot of endos, over time you can become very good in perio, and same goes for the other fields as well.
Right, sir. Thank you for that. So, sir, since we're talking about perio again, so what is the scope if we talk about Canada for perio? Because there will be students who will be listening to us, and it's in they would be in that phase where they know that they have to do something, and Canada seems to be a very optimum option these days. So, what is your advice to those students who are opting for Canada in terms of perio?
So I'll I'll give the answers. I'll give the answer in a way that it will be general initially, and then I'll talk specifically perio if it's okay with you. Growing up, when I was in second year BDS, and it's especially unfortunately people from North America, Canada, they may not have an appreciation, they may not understand, but we come from a third world country, a developing country, which is Pakistan. So we have a growing up huge population, limited opportunities, so it makes us competitive, and it creates an environment where you want to get out, do something, and hopefully achieve great things. So growing up, I was in second year of dental school when my uncle, he's dean of, I think, Ajman University in UAE. God bless him. Amazing advice. So what he told me was, I was in second year, and he said, Mo, we will meet again. He would come every year. To this day, he visits my family every year. Amazing, amazing relationship. He said, Mo, we will meet again after 2 years when we will talk about this particular thing that I'm going to say to you today. Over the next 2 years, I want you to develop a hobby. Any free time you have, you will sit on the internet, you will find all the different schools in all the different countries across different continents offering dental programs. I want you to make a register. Now, remember, back in the day, we're talking about 2006 and 7, the information was scarce. Not everything was on the internet. The internet speed was very slow, and we're talking about Pakistan, right? So gathering all that information was difficult back then. So he said, I want you to make a register. You will write down country name, university name, program name, application deadline, everything. And I want you to make a full register, gather all the information. When I meet you after 2 years, I don't want you to be able to open the book and read that stuff. No. After 2 years, if I say Turkey, you should be saying Marmara University, Yeditepe University, ortho program is 3 years. For example, Yeditepe University, $20,000 US for 1 year. It used to be that. I want all the information. It should be on your fingertips. And I said, okay, I'll do it. And he was telling me, he met me recently and he says, Mo, I give your example to my students now. Because he says, I tell them after 2 years, my nephew pretty much knew about all the programs across different continents and major universities. So that is one thing. You need to prepare. The extra time that you get, spend towards gathering information. Information is key. And you can use it in any field. What do you want to do? So at one stage, there was a chance I might end up going to China. I started learning Mandarin. I don't remember it because that was back in 2011. I never used it. I never went there. But I thought, okay, if there is an opportunity, I'll try my best. I started learning Mandarin and I could make small talk. Like to this day, I was in the bank and the manager was Mandarin and I said, ni hao ma, han hao. Like I can speak a little bit. Similarly, when I was at McGill, I came in doing a non-thesis MSc. My goal was I want to be good enough. I had zero knowledge about research or anything. My goal was I want to be good enough so that I'm offered a PhD position. By the end of first semester, God bless my supervisor, and I cannot thank her enough, Dr. Mari Kartanen. She said, Mo, I have a PhD position for you. So, and what did I do? I had to wean, keep mice, do their DNA sampling and all that. No idea. You have gone through the BDS, right? No clue how I'm going to do it. And I had a lot more courses than people who were doing thesis based. So the only time, sometimes I went to lab to do my work at 2 at night or 3 at night. And I finished my MSc in about 1 year and 5 months, I think. I did my coursework, completed everything. It was a 2 years program. And during that time, I went to, for example, I wanted to take some time off if I could in between. Sometimes I went to swimming pool to swim to get some exercise in at 3 at night because I didn't have time in the day. And when I finished my program, my time spent at McGill, somebody was asking me the other day about French. Did you learn French? I said, no, because I wanted to, yes, I should have, but I spent my time so that, by the time I finished McGill, I ended up getting, I think, 6, 7 publications out of that time, from that time, which was amazing. So coming to your point, if you want to succeed, not just perio, make sure you keep all the options open. Try. I'm saying this specifically for Pakistan. People in North America may not understand, but in context of Pakistan, try your best, use your time, and try to make the most of it. So that's a general advice. Now, coming to perio, you said about scope. I cannot be enough thankful. I am so grateful for the opportunity. I'm grateful to Canada, Canadians, uh, everybody here. Just cannot thank enough. It's a land of opportunity. People say that about US. I can say it about Canada. Perio is a great field, amazing field. The only problem is, just like any other field, it's super competitive. It is insanely competitive, not just perio. I'll give you an example. So in US, there are 60, 70 dental schools, okay? Each school, let's say, to make math very simple, let's say each school let's pretend there are 70 schools and each school takes 3 residents, let's just say. So in a round figure, we're looking at 210 residents being accepted per year, in a round figure, let's say. In Canada, I program 2 to 3 residents. Yes, the population is less, I understand. But what people don't realize is people from all different nations are immigrating to Canada. People with amazing credentials are coming to Canada. So there was a guy, I'll give an example. There was a guy, he was a professor, principal of a very famous college in a country. A specialist had done his master's from a European country, a PhD from North America. He applied, he was not accepted. Okay, so it's so competitive. In order to have a good chance, what you need to do is work on your resume, your skill, how you can improve, how you can improve, be better, not just in perio, but in any field. And even if you've you've been blessed that you've achieved something, improve, excel. So it's amazing, but it's very competitive.
Right, sir. So again, one question that comes to our mind is the difference between experience and training. How would you answer that question?
So, like, reminds me of another thing. I apologize. When you apply for a job, what do they say? You need to have 2 years experience or 5 years experience, right? Well, I'm a fresh graduate, then will not give you a job. Well, if you don't give me the job, I will not get the experience, right? So where do I go? So training is in context. Let's put it in context of perio, okay, or dentistry. So I'll use my example. Uh, let's say it was my residency time, right? I go in there, I am being trained. My instructors are there, God bless them. They're teaching me do this, whatever. We go through the mill, you learn through training. Then over time, a time comes, hopefully, when you can look at a thing and you can say, you know what, in this case, I'll do this, I'll use this technique, I will do this, or this. And somebody may ask why or how can you say it? Like, okay, I understand you're going to do a connective tissue graft, but why would you do a tunnel here versus a Kelly technique or this? And you say, I just know it. I just know it. Like, this will work here. And then, okay, yes, you can defend it, you can explain. But even before you explain or defend, when you say you know it, or in your heart, this is how you know it, that's experience. And no substitute for experience. Training is a must. Training leads you to be in a position where hopefully you improve and you gain experience. It's not like, either or. You need to have both. But experience, I am privileged. I cannot be enough thankful. The practice where I work, we have a periodontist, Don, amazing guy. He's been doing perio for the last, I think, approximately in around figure 40 years. Another periodontist who has two brothers who are plastic surgeons in Hollywood. And those two brothers say that our sister is a much better surgeon. And another periodontist who is one of the very best in the world. In my experience, she's only worked for the last 10, 12 years, but in my experience, I've seen her work. I've seen a lot of people's work, and I've seen the volume of work as well. This colleague of mine, in my experience, she's worked more than people typically do in 25 years. So it's nice, like, when you sit among such a company and they discuss cases, like, especially when I came, I felt intimidated initially. Like, I had already had, I think, about 1.5 years of private practice experience when I came in this practice. And I was like, wow. And when they tell me, like, when we're talking the other day, my colleague was asking me, Mo, how would you place the implant there? And I felt like, no, you're too good. Like, I'm nobody compared to you. I'm just nobody. But it gave me immense satisfaction that she considered me worthy enough that she asked me, like, she's the best. I'm just like, an average Joe. So that experience is there is no substitute, but it comes with time. But you need to have the training to be able to execute, and that repeated execution over time will give you experience. When I had my first bleeder, I remember I was telling this to my colleague yesterday. I said, I was in private practice when I had a major bleeder in the greater palatine artery was like, pss, 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 pss. During training, I didn't have it, but I saw it. Somebody else's case, I did see. But it was a real life situation. My first experience, didn't panic, managed. Took me about half an hour of suturing, but it was completely fine. Patient was good. But that experience now is invaluable. It's just amazing. Yesterday, when my colleague was saying that, there's a little bit of bleeding, I said, dude, relax. We'll take care of it. Don't worry, right? So experience is just priceless, but training leads to that experience over time.
Right, sir. Thank you for that. So, sir, another question which I, had the, you can say, I thought about all these questions, and this question came to my mind that the new technologies in perio and implants. So we've seen that perio is going way beyond from, your soft tissue surgeries, like they would do connective tissue grafts, and now they're doing like something else. Like the work has improved ginormously. So what are the new techniques which are coming in perio and implants as well?
There are a lot of new things which are being like, I think one another important thing. Any industry, think about it this way. Oral and maxillofacial surgery. Why everybody talks about perio now? Prosto as well a little bit, but perio is at the forefront, I believe. Two reasons. One, one reason I don't think a lot of people know. The second is obvious. What is the first reason? Interestingly, most research, even for oral maxillofacial surgery, is done in perio. Most number of publications, it used to be about 100,000 articles per year, give and take. I don't know now, but that's what I knew back in the residency, are published in good quality journals, roughly around the globe. And bone research, basic science research, healing, all that is done or falls under the domain of perio. So perio is essential in that regard. And perio is connected to other body as well, like systems. So that makes sense. But from marketing, from financial side of things, all the companies, if they have something which they can make and sell, they would promote it as well. So perio has the tools. When it comes to oral surgery, I'll give you an example. Most oral surgeons here, what do? They do wisdom teeth extraction or IV sedation. What do you need for wisdom teeth extraction? A forceps elevators, burrs, handpiece. It's not fancy. Like, you'll sell it once, it will last a long time. So from a company's perspective, probably not too beneficial to promote that, right? From perio, you have different implants, different designs, different surfaces, healing abutments, then cover screws, then different drills. Like there are so many things that you can sell. That is why you see a lot of marketing there, right? So that's why perio is at the forefront. Having said that, I am a firm, and I understand a lot of things are being thrown. So much, it's rapid. The evolving perio thing, it's rapid, it's huge, I understand. But I am a firm believer in the fundamentals as well. You need to have a very solid base. On top of that, you can build stuff. Now, there are many things I know, like, for people who may not know, so I'll put it simply. We have guided surgery, has been there for quite some time. Another one is nav system, where basically you're placing the implant, you're looking at the screen while you're placing the implant. It shows you live CBCT based implant placement. Same in the grafts, like, same in the bone grafts, same in soft tissue grafting. This is all cool. This is all amazing, but you need to have very good fundamentals. I'll give you an example. I was placing an implant and I was using a surgical guide, fully guided everything. I did my initial drill and I took a radiograph, looked good, but clinically the emergence did not look that good. I was amazed. Like, I checked my guide. I wanted to make sure that it was snug fitting. There was no flaw. But we know there are errors in CBCT. There are errors and we had taken a scan impression, intraoral scanning, but there are errors, and those errors are amplified when you're making a guide. So I removed the guide and I placed the implant manually. And I was joking that day. I told my staff, I said, I'm so happy, so grateful that I placed many implants with my hands in my training. Because if that wasn't the case, if I was completely technology dependent, I would like, okay, what I do? Stop the procedure, call the patient in. So despite all these things, the fundamentals have to be there. You should be able to do all the basic necessary. Yesterday, I saw a case where regenerative surgery had been done 5 years ago. And in my opinion, I could be wrong. That case was not appropriate for regenerative. So I told the patient that, we'll probably end up doing the traditional perioresective approach. It was a posterior lower left. So you need to have all the tools, and then the new technology should facilitate, should improve, but it should be time tested, and it should also be like, basic science level. It should be very thorough, meticulously tested. And then if it comes in, yes. On a side note, which is connected to the thing we discussed, it depends on where you practice as well. On a side note, for example, in my training as well, like, you could do the block graft, the harvest, and all those things. And in Pakistan, when it comes to bone grafting, a lot of times we just do it that way. But given I am in North America, a lot of patients don't accept it. They don't want it. So that's where the technology helps. And you're like, okay, I'll use some substitutes, a membrane, I'll pack some bone from outside, I'll not harvest your bone. So the technology is amazing. A lot of new things are coming in, but before hopping or jumping onto them straight away, fundamentals, basic, necessary, and any technology should be very thoroughly tested. And after that, if you practice, improve, and when you're comfortable, only then you should go live.
All right, sir. Now we'll take in some mythbusters. So the first question is, does scaling make our teeth weak?
Okay, no, it's important. And it's so funny because a lot of my colleagues, my really good dear friends from Pakistan, they just sometimes they give me a call. Mo, my dentist, he is asking me to have scaling done twice a year or something. I'm like, dude, it's important. Please do it. No, it's important. It's really important. Please have your teeth cleaned.
Right, sir. So
Professionally, that
another
is.
question related to scaling: does scaling make our teeth sensitive?
It may. It may sometimes. Depends case to case, but just like periosurgery. So when I do periosurgery, flap procedure, for example, I'll tell the patient there is a likelihood, there's a possibility that there will be some transient temporary sensitivity. Don't be alarmed. Over time, it will go away. And if you can use a certain toothpaste, let's say, which has strontium or potassium salt, you'll be fine. Don't worry about it. But when you give somebody an injection, let's say for does an injection cause discomfort? Yes. Then why do you take it? Well, it's essential. Same thing is true for scaling. Another example, if let's say you wake up in the morning and you rub your eye, God forbid if blood was coming through your eye, would you be comfortable? You'd be like, oh my God, what's happening? No. So when blood is coming through your gums, why should you be comfortable? You shouldn't be comfortable. Just saying.
Right. So, sir, another question. Again, you talked about toothpaste. So, what do you think is the perfect toothpaste for sensitivity?
I don't know. Like, you're putting me another interesting thing. I'll answer it slightly differently. I've had this question asked. So when I talk about hygiene to my patients, they say sometimes, I hope Oral B doesn't listen to this, okay? So they ask me about the toothpaste and brush and whatnot. And I, after the surgery, when I see them after 2-3 weeks, whatever, I say use a soft brush and I'll go over the brushing technique. And then they would say, Mo, I have an electric toothbrush. And then I say, okay, there are two different types of electric toothbrush, chiefly. There are other as well, but two main big companies, one of which is Sonic Care. And I say, I wish I had shares in Sonic Care. I don't have any shares in Sonic Care. I don't have any trust. But I say the mechanism of action of Sonic Care is different than compared to B. So same thing, if you, basic thing is if it's a good toothpaste, has fluoride, has strontium, potassium, and all those things, it's okay. Like the problem is people don't brush teeth. It's not the toothpaste is not the problem. So please brush teeth. That's the bottom line.
All right. So, sir, again, there is this fallacy or this question or a myth that teeth cleaning and teeth whitening are the same thing. So, what's your take on that?
Okay. Okay. So teeth whitening, if you want to do it, if you're a YouTuber, if you're somebody like, okay, I am sorry, but it reminds me of another question. When I was practicing elsewhere in another city, a lot of times, like, patients would come to see me and they would say, I want that Hollywood smile. And I'm thinking, okay, your perio is like, bone-wise things are really bad. We need to stabilize that first and then go from there. So teeth whitening, aesthetics, all that, I understand. But at the end of the day, the cleaning is more important, especially in the context of a bigger picture. Um, God forbid, I've seen a lot of cases where men and women in their 40s lose all the teeth. I've seen a lot of those cases, unfortunately. Or in their 50s where all the teeth are wiggly, like, they can blow with air and they end up having dentures. So, not that teeth cleaning will prevent that in every single case, but that will reduce the rate of bone loss, periodontal loss, even in the worst of cases. So, teeth cleaning it is.
Right, sir. So, another question which is readily asked, is that is the dental implant procedure a painful procedure or not?
Again, like, every case is different. And why do I say that? I've had cases, I've had the experience where sometimes you're amazed, like, there shouldn't be any pain here, but there is pain. But generally, if I was to give a general statement, at least in my experience, in my hands, I tell my patients, and my colleagues and the staff who works for me can attest to it, when I joke a lot during the procedure to reduce the anxiety. So I tell the patients, I say, if I've extracted your tooth, if you've had the extraction, I would typically ask them, like, let's say you've come to me, you had a tooth extracted elsewhere. What was your experience on a scale of 1 to 10? Where would you put the pain? They may say 5, they may say 6, they may say 7. I would say generally the implant would be way much easier, nicer, smooth, not a problem. Should be a walk in the park. Very simple, very easy. Pain wise, don't worry about it. The worst part of the procedure, my typical thing is I tell them the worst part of the procedure is the anesthetic. If you've had dental freezing before, then your approach, chill and relax, enjoy the ride, you'll be fine. Very simple. In most cases, pain shouldn't be an issue.
Right, sir. Another question related to implants. Do implants fail very often?
Now there are two, how do you define a failure? It's a little academic. To put it simply, one thing is survival. What is survival? I'll try to make it very simple. Survival means you've put the implant in the bone, you let it sit, and after 4 or 5 months, you come in and you test if this implant has become integrated with the bone. When you test in terms of integrity, in terms of implant being bonded to the bone solidly, it's about 97 to 98% typically. Now, the other is success. What is success? Success can be defined differently. Success means if you've placed the implant, you hope, wish, and pray that implant stays for a long period of time, complications free, or with very minimal complications. So, a very nice paper was Elbergson 1986 or 80, I'm forgetting the year, where they came up with a certain criteria. Like, it has to be this. Stringent criteria. Based on that criteria, after 10 years, 80% implants were still considered successful, which is very good. But that doesn't mean the 20% failed to integrate. They were still in the mouth, they were still functional, majority of them, but they were not the gold standard level implants. Like, in terms of marks, you may give them 80, you may give them 70, but they're functional and the patient may or may not have issue with them. So in a nutshell, if somebody asks me, are implants successful? If I wanted to give an answer to a layperson, I would say implants are the best substitute for a natural tooth. But in my opinion, natural teeth are still the way to go.
Right, sir. So the final question about on this Mythbuster session is that is bone grafting compulsory for implant?
So previously, like, in 200 BC, let's say the implants were placed where the bone was. So let's say, like, you want to place an implant and you open up the area and you're like, okay, where is the bone? This is the bone. This is where I'll drill. I'll put the implant. The prosthodontist or the restoring dentist, come on, dude, this is your job. You just restore it. Do it anyway. Things have changed now. Now we look at it's prosthetically driven, which simply means the patient comes to you, you look at the area, you listen to what the patient wants, then you explain that, okay, the patient wants a perfect tooth, a perfect smile and everything. You look at the area and you say, you know what, okay, I'll try to put the final crown, the final tooth, because for patient, crown doesn't make sense, tooth is what they want. So we tell them, okay, this is where we would want to put the final crown. If my final crown is here, I cannot put my implant here. It has to somehow come here. If I'm talking about an upper, let's say, right? 1 1 2 1. This is my final crown coming out like this. My implant has to follow. How do I make it happen? I can use an angle screw. I can use a bone graft. So in those cases where there is not enough bone to prosthetically or place the crown in the ideal position, we need to put the implant in optimal position, and for that, bone grafting does become essential.
Right, sir.
But one more thing, if I
Yes, sir.
may add, please. In today's world, with the substitutes that we have, like, with IV sedation and everything, we can reduce the anxiety. Patient is, like, not fully at a conscious level, moderately sedated, whatever. But also, prior to that, a lot of people, they're not comfortable having bone taken out from their jaw. So to them, we can say, we have substitutes with which we can build, hopefully, good enough bone that we can place the implant in an optimal position for prosthetically driven treatment.
All right, sir. Sir, thank you so much for your time.
My
And
pleasure. I'm
for
grateful.
for the final for your final thoughts and any message would you would like to give to our dental students, our dental professionals over here in Pakistan?
Keep learning, keep improving, and put in the hours, put in the work. There are no shortcuts, takes time. But, like, if you keep doing good work, and one thing I would suggest to you is, at the end of the day, when you're done, if you're a professional doing dentistry, at the end of the day, once you're done with your work, sit back, look at the case, and think about it, how you could have improved. And if you're a student, explore all the avenues. If you're in Pakistan, again, I'm saying this again and again because a lot of people will not understand in North America, look at all the options. It's very competitive, it's not easy. So in your extra time, in your spare time, look at, okay, where else can I apply? What are the different options? If I do this particular program, can I give? Because in Pakistan, we typically go with fellowships from England. Is this program approved there? And how's the quality of the training? What specialty, like, what certificate will I get? How much experience, how many clinical hours I will get there? So all those things, like, make the most of your time while you're a student. And your hobby should also be such that it helps in your professional development. So as long as you do that, hope, wish, and pray, you'll be fine.
All right, sir. Thank you so much for your time, and I hope that all the people who are listening to us will gather all these pearls of information, pearls of wisdom from you, and I hope, inshallah, they'll do better in their fields of life.
That's what I hope for. That's what I
Thank you so much for your time, sir, and I hope you stay well.
Thank you, sir. Super grateful. Have a good one.
Thank you, sir. Take care.